the people joining?
Yes, sir. Here you can see the participants. All attendees can be listed here.
Oh, only that, huh? So, Pujita, I can't see the attendees.
No, sir. Disabled it.
Oh, you are disabled it. I think you should enable that so that we can have talking to each other. You know, the
No, this is a webinar one. Only
Yeah,
the
it's not like a
academic
meeting kind of.
only webinar. So it's not a meeting like
No,
it's not a meeting.
Because if you are switching on the meeting, everybody is switching on their videos and
We'll start it in the middle. Entire video comes.
Okay, sir. So here is it.
Yes.
Hello. Hello.
No, you continue, sir.
Sir, we can start.
Can you? No, I want to know whether the students are
No,
here.
student can hear, sir.
Yeah. Good morning. Today we are going to learn about one of the important topic in pediatrics. That is the acute rheumatic fever, and it has been one of the scourge which is affecting the developing countries for a long period of time. And of late, we are not been encountering as many cases as we used to in 60s and 70s. But whatsoever, we should try and learn and try to identify when you come across a child with acute rheumatic fever. And it happens to be one of the differential diagnoses for many of the children with fever and joint pains. So, by definition, it's a multi-system disease predominantly seen in children between the ages of 5 years and 15 years. It's very rare to see acute rheumatic fever in less than 5 years or in adolescent and adult period. But it is known that the acute rheumatic fever can have an onset during the adolescent period and also sometimes, rarely, in adult period also. And usually it is preceded by group A beta hemolytic streptococcus sore throat. This is one of the commonest cause for a sore throat in children apart from the viruses. Majority of the sore throat are due to the viruses, but there are certain telling clinical symptomatology which tells you that this could be a group A beta hemolytic streptococcus sore throat. The exact pathogenetic mechanism is not known. We'll come to that later. A group A beta hemolytic streptococcus is one of the serotypes which you see in a group A streptococcus. The group A streptococcus is otherwise known as a streptococcus pyogenes. And there are many types of strains of streptococcus. And group A beta is that it has a complete hemolysis which you can see on a blood agar gel when you media culture the organism. There are multiple serotypes, but not all serotypes are metagenic. Well-known serotypes, the M types is 1, 3, 5, 6, 18, and 29. Likewise, there are also nephrogenic strains which are completely different and which usually causes skin infection. So the throat infection is more common with these serotypes, and usually the throat infection precedes the onset of acute rheumatic fever. Skin infection do not precede acute rheumatic fever. Usually there will be 2 to 3 weeks interval between sore throat and the onset of symptoms of acute rheumatic fever. And that is a temporal relationship between the two. And you'll also find that there is a increasing titers of anti-streptolized low antibodies and an increasing titers of anti-DNase, anti-hyaluronidase. Isolation of streptococcal organisms or antigen from the throat is sometimes possible when the child comes with acute rheumatic fever, but it may not be. because usually the organisms are found in the throat during the acute sore throat period only. Then there will be an increased levels of acute phase reactants like ESR, C-reactive protein, procalcitonin, and other acute phase reactants. The pathogenesis, how the infection with group A beta hemolytic streptococcus causes the acute rheumatic fever is definitely not known. One of the things is the enzymes, streptolysin O, can induce a myocardial damage and also can affect the various tissues, particularly the joint and other tissues. But this may not be the exact pathogenic mechanism because streptolysin O, by the time the child develops the acute rheumatic fever, it is not present as the enzyme because by that time the anti-streptolysin O has already been produced and then the streptolysin O is cleared off. Then the other theory is that there may be a molecular mimicry between the streptococcal antigens and antigens of the cartilage, joints, heart walls, and also other cartilaginous structures. Yeah, this is most probably the pathogenic mechanism which we all believe that is the cause for the development of acute rheumatic fever. The M antigens they can alter the synthesis of type 4 cartilage and then cause disease. But once you say that altering the synthesis of type 4 cartilage, the cartilage tissue in the cardiac valves are affected and disability can occur. But the joint cartilage, there is no damage because there is a complete recovery of the whatever the joint inflammation which you see. So this theory also cannot be completely true. It's most common in developing countries, the acute rheumatic fever, and you see in low socioeconomic strata of the population, wherever there is overcrowding, poor hygiene, both personal and environmental hygiene, and all these characteristics pre- predisposes for higher incidence or higher risk for recurrent sore throat, such as streptococcal sore throat. So when the child develops recurrent sore throat, then they are more prone for developing an acute rheumatic fever. And the incidence is something about 50 per 100,000 population if it is in low risk countries like in developed countries, America, Europe, whereas it can be a 100 to 200 per 100,000 population in developing countries like India. Clinical manifestations, as the name suggests, acute rheumatic fever, fever must be there. So the child comes to you with a fever, which is usually more than 38.5 degrees centigrade or 38 degrees centigrade. And it is not very high grade fever, and there is no characteristic feature of for the fever. Then the child develops arthritis, and it's classically described as a migratory polyarthritis. The migratory polyarthritis means that one joint will be involved at the onset and it is swollen, red, tender at the limited movements, and then it will be there for about 3 to 4 days. It disappears even without treatment, and then only to appear in another joint. So likewise, it keeps on moving from one joint to another joint. Sometimes there may not be a full arthritic manifestations. There may be a just pain in the joints, maybe with a little bit of a limitation of movement. That is what you call a polyarthralgia. I will come back to that after at a later stage when I say that how polyarthralgia can also be considered as one of the important clinical feature of acute rheumatic fever. And then there is a carditis, that is one of the most important clinical manifestation of acute rheumatic fever, and that is the one which leads on to the chronic rheumatic heart diseases and then complications, and it is going to be a lifelong disability. Of course, the other, I think the Chorea should have come up because that is much more common than erythema marginatum and subcutaneous nodules. The Chorea is one of the clinical manifestations which we see as a part of acute rheumatic fever, but usually it occurs in isolation. There are no associated finding, even a fever, and definitely not polyarthritis. You just imagine a child with polyarthritis developing a chorea and how painful it will be. Probably the nature has seen to that the chorea occurs separately from polyarthritis. So chorea is another clinical manifestation which you are going to deal in detail at a later stage. And the less common manifestation of an acute rheumatic fever is erythema marginatum and the subcutaneous nodules. And of course, there is a elevated acute phase reactant. In high ESR, C-reactive protein will be increased. A prolonged PR interval on ECG. This is a finding. If there is no carditis, if you are dealing only a child with rheumatic arthritis, polyarthritis, migratory polyarthritis, then you take a ECG and then look for a prolonged PR interval. Then you know that it is a acute rheumatic fever. But if there is already a carditis, then there is this clinical sign may not be very important. Now, the clinical manifestations are so different from one another, it is very difficult to make a diagnosis of acute rheumatic fever based only on those clinical manifestations. So somewhere in 1947-48, early in the investigation for acute rheumatic fever, the Jones criteria was brought into this one, and it has been modified many times in the last few years. The latest one is a modified Jones criteria in 2015. The criteria are divided into major criteria, minor criteria, and supporting criteria. Major criteria, you can select it. Minor criteria, you can select it. But supporting criteria is a must. It has to be there, whatever the combination of major and minor criteria combination you are looking for. The major criteria are polyarthritis and monoarthritis. Sometimes it can be considered as a feature of rheumatic fever, particularly if the child has not taken any analgesics or aspirin. If the aspirin is taken, if the child comes to you with monoarthritis, it is not a clinical or a major criteria for acute rheumatic fever. Polyarthralgia, yes, this is where it's important. In moderate to high risk population, polyarthralgia, fever with other clinical characteristics, it can be taken as one of the major criteria. But you must always look for a polyarthritis rather than polyarthralgia. In a low risk population, polyarthralgia is not a major criteria. It is included under the minor criteria. Then the second major criteria is a carditis. Is the second one. It's a carditis, erythema marginatum, subcutaneous nodules, and chorea. They are all the major. Minor criteria is fever is more than 38 degrees centigrade in a high risk population. Whereas in a low risk population, the fever of more than 38.5 is taken as a criteria. Polyarthralgia, as I have already discussed earlier, it can also be included in the minor criteria. Then ESR, more than 30 millimeter at the end of 1 hour in moderate to high risk, whereas in a low risk population, it has to be more than 60 millimeter per at the end of 1 hour in low risk populations. And of course, there is an increased C-reactive protein as a product, acute phase reactant, and I have already discussed about the prolonged PR interval in the absence of carditis as a minor criteria. Supporting criteria is to see the evidence for the preceding streptococcal infection, group A beta hemolytic streptococcal infection. Definitive evidence is a positive through culture. But by the time the child presents with the acute rheumatic fever manifestations, the throat culture may not be positive. Organism would have disappeared from the throat. So then you will have to look for other indirect evidences. In the acute stage, you can also do a rapid streptococcal antigen test, which will be available within 6 hours after doing the test, and we will know whether the child is suffering from a sore throat or streptococcus is present in the throat or not. So, but that is going to be very helpful in managing acute sore throat. It may not be positive in a child with an acute rheumatic fever. And then, of course, this is a important one: elevated or increasing anti-streptococcal antibody titers. We'll come to that. What are the anti-streptococcal antibody titers, which we are going to look for at a later stage. The low risk is considered as if it is less than 2 per 100,000 school-going children. High risk is more than 2 per 100,000 children. And are all age rheumatic heart disease more than 1 per 1,000 population. This is how you classify a population as a low risk or a high risk population. So now once we know the criteria, if there are two major criteria are present, then the child is definitely are suffering from acute rheumatic fever. Or it could be a one major and a two minor criteria. Any of the two minor criteria, any one of the major criteria, yes, the child is definitely having a acute rheumatic fever. Sometimes three minor criteria in moderate to high risk population can be considered as suggestive of acute rheumatic fever. It is not three minor criteria may not be taken into account in a low risk population, but in moderate to high risk population, sometimes it can be taken into consideration. And plus, one of the supporting criteria must be present. With all these three, there must be one of the supporting criteria should be positive, and this is plus two major criteria plus supporting criteria, one major, two minor criteria plus supporting criteria, three minor criteria plus supporting criteria. That should be the inference when you look at the Jones criteria. Now let us come to the each thing, clinical manifestation. Arthritis is the most common clinical manifestation. There is a swelling, warmth, pain, tenderness, and restriction of the movement. That is a classical description of an arthritic joint. Arthralgia is a painful joint, but without signs of inflammation. The swelling, warmth, pain, tenderness, restriction of movement, they are all clinical signs of inflammation. Polyarthritis is a major criteria, as we discussed already. Polyarthralgia, monoarticular arthritis, if the child has not received aspirin pertaining to the monoarticular arthritis in high-risk group can be considered as major criteria. But before considering polyarthralgia or monoarticular arthritis, you have to rule out the other causes for polyarthralgia and also other causes for monoarticular arthritis. And then you can take it as a major criteria for acute rheumatic fever. It occurs in 75% of the children with acute rheumatic fever, so it's not 100%. There are children who can present only with fever and carditis, or no carditis, no arthritis, they can present with chorea. It is migratory or fleeting in character, which I have already explained to you. The ankle, knees, wrist, elbows are commonly involved. That shows that larger joints are involved. Hip, spine, and smaller joint, not usually involved, but it can be. Okay. A dramatic response to salicylate, even a low dose salicylates, will remove the acute inflammation and arthritis disappears. It is one of the clinical characteristics of rheumatic fever arthritis. If there is no response to aspirin, whatever the dose you give, you should think of other possibility other than acute rheumatic fever. And the arthritis of rheumatic fever, it is never deforming. unlike in a juvenile rheumatoid arthritis or other arthritis, other causes of arthritis. Usually you can see some deformation of the joints, but in rheumatic fever, you never see. The classical description is the acute rheumatic fever, it clicks the joint, bites the part. That means that it clicks and produces transient clinical manifestation of arthritis. Whereas when it bites the cardiac tissue, there is a long-term consequences of that inflammation. If you do a synovial fluid during the acute stage, particularly in monoarthritis, where you are suspecting a septic arthritis, the analysis will show you that there will be a plenty of WBCs. Protein will be up to 4 gram per deciliter and a normal glucose level, and it is sterile. Whereas in septic arthritis, effusion, it's a more of pus which you aspirate, and glucose will be decreased, and it is not sterile. And severity of arthritis is inversely proportional to the severity of the carditis. More severe the arthritis, the carditis is less severe, less deformed. Low severity of arthritis usually tells you that this child may develop a severe carditis with their long-term consequences. Carditis is a major criteria, occurs in 50 to 60% of the children with acute rheumatic fever. Clinical carditis with murmur of valvulitis. Whenever there is a inflammation of the valves, they don't close properly. Okay? So because of that, there will be murmurs, sounds are heard. The turbulence of flow across the valves can be heard. That is what we call as a clinical carditis. That is the major criteria. But nowadays, they also say that there is something called a subclinical carditis. That is without murmur. When you ascertain if there is no murmur, you are not going to say that, okay, this is not there is no carditis. But there is something called as a subclinical carditis, where there are echo findings of valvular involvement. So any child where you are suspecting acute rheumatic fever, echocardiography becomes an important tool to identify the children with subclinical carditis so that you can uh, make a definitive diagnosis of acute rheumatic fever and then prognosticate the long-term consequences. Now, if you look at the echo findings on the subclinical carditis, there are two valves which are commonly involved in acute rheumatic carditis. One is a mitral valve and the other one is a aortic valve. Both causes regurgitation in both the valves. So these are some of the clinical findings on echo, seen in at least two views, jet length more than 2 centimeter in at least one view, peak velocity of more than 3 meters per second, and pansystolic jet in at least one envelope. But the aortic regurgitation, almost a similar criteria, similar thing, where we are going to see, look at the jet length, peak velocity, and the systolic jet, pansystolic or systolic jet. Whereas in aortic regurgitation, the difference is a pan-diastolic jet. It's a diastolic murmur in aortic regurgitation, not a systolic murmur. Whereas in mitral regurgitation is a systolic murmur, which you hear. Usually it affects or can affect all the three parts of the cardium or heart. Pericardium, myocardium, endocardium. Endocardium includes the valvular involvement. But predominantly it is an endocarditis with a valvular involvement. Myocarditis and pericarditis without endocarditis is not a rheumatic origin. Child has a fever, maybe arthralgia or arthritis, but child also has a pericarditis or myocarditis, but there is no evidence of endocarditis. It cannot be an acute rheumatic fever. Carditis usually presents with tachycardia, dyspnea, orthopnea, parajuvenile nocturnal dyspnea, depending upon the amount of valvular damage which has been there. Cardiomegaly on chest X-ray, heart failure, clinical signs of heart failure will be there, hepatomegaly, peripheral edema, and a pulmonary edema, and a gallop rhythm. And of course, there may be a cardiogenic shock. It is a very rare phenomenon which you see in acute rheumatic fever. Auscultation reveals a pansystolic murmur at the apex along with the mid-diastolic flow murmur, suggestive of a mitral regurgitation. There may be early decrescendo diastolic murmur at the aortic area, suggestive of aortic regurgitation. The mitral stenosis and aortic stenosis occurs after many years with recurrent episodes of carditis. This is mitral stenosis and aortic stenosis are a consequence of recurrent acute rheumatic fever with carditis. It is the stenotic lesions are not seen during the acute stage of acute rheumatic fever with carditis. Sometimes the initial severity of the carditis may result in long-term consequences. One episode of severe carditis may end up with a long-term consequences. We'll come to the Chorea. It occurs only in 10 to 15% of the children with acute rheumatic fever. It is not very common. And it's an isolated presentation, as I told you earlier, not associated with other criteria. There would be usually a long gap between the onset of chorea and the preceding gas infection. Probably the patient or the parents would have forgotten about the sore throat the child has had long time ago. There is no evidence of group A streptococcus infection or elevated acute phase reactants in a child with chorea. And of course, chorea does not lead to a permanent sequelae as the arthritis. Chorea, it is a subtle movement disorder. Usually it is associated with emotional liability. It is a very important feature of chorea. If there is no emotional liability, it may not be a chorea, and then other movement disorder should be considered. There is a incoordination, there is poor school performance over a period of time, facial grimacing for no reasons, uncontrollable movements are present, and usually they are precipitated by stress. Disappears during sleep is very characteristic feature of chorea. When the child is sleeping, the movement disappears completely. If the movement persists during sleep, then it is not a chorea, Sydenham's chorea or acute rheumatic fever chorea. It's rarely present as hemichorea, yes. But if the child presents with hemichorea, then think of other diagnoses before thinking of acute rheumatic fever. Chorea, there are typical signs which you are going to elicit. That is a milkmaid sign. You ask the child, grip your fingers, and then you see that the child will start doing this, like you are milking the cow. So that is what you call as a milkmaid sign. Then spooning and pronation of the hands which are extended. So now you do this or do this. Usually it goes like this. Okay? Or you do this, ask him to extend like this, it goes automatically into this position. So that is one of the clinical signs which you are going to elicit. And of course, wormy and darting movements of the tongue. Ask him to put out the tongue. So it will be just moving out, in and out, and then side by side, and then you can see the contraction of the tongue muscles. Then, of course, you ask him to write worsening handwriting, which can be used as one of the prognosticating tests for the children with chorea. Over a period of time, the handwriting improves. Then you know that the child is coming out of the chorea. Erythema marginatum is very rare. Only 1% of the children with acute rheumatic fever. It's a characteristic rash, erythematous, serpiginous, macular. It's not itchy, mainly on the trunk and not on the face. Warming the skin, it becomes more prominent. That's a characteristic feature of erythema marginatum. Subcutaneous nodules are very rare. Firm nodules, 1 centimeter in size. Extensor surfaces are usually involved. Usually you feel here on the back of the thing, on the back of the fist and on over the joint, feel this one over the shin. That's where you see the subcutaneous nodules. And usually they are near the tendons and bony prominences. They are not tender. Strong correlation between nodules and the medical. Acute rheumatic fever, a child comes to you and then you feel the nodules during the acute stage. That means that the child is going to develop or child is already having a carditis. The differential diagnoses are many. Each thing has to be considered separately. For arthritis, there is a reactive arthritis, juvenile rheumatoid arthritis, serum sickness, systemic lupus erythematosus, septic arthritis, Lyme's disease, post-streptococcal arthritis. These are all some of the differential diagnoses. Then there is a viral myocarditis for differential diagnosis of carditis, viral myocarditis, viral pericarditis, bacterial endocarditis, Kawasaki disease, acyanotic congenital heart disease, mitral valve prolapse, innocent murmurs. They all come into the differential diagnosis of carditis. A differential diagnosis of chorea, is it an Huntington's chorea, Wilson's disease, systemic lupus erythematosus, cerebral palsy, tic disorder, hyperactivity? These are all some of the differential diagnoses which you have to investigations. What investigation you would like to order? Yes, you would like to look at the complete blood counts and then look at the ESR, C-reactive protein, which has to be serially measured. And then you do an ASL titer, which has to be serially measured. Anti-DNAs, which has to be serially measured. Anti-hydrolase is another anti-streptococcal antibodies, which has to be serially measured. And then don't take any one of these in isolation. It may not be suggestive of an acute rheumatic fever. When you take ASL titer and anti-DNAs antibodies together, the chances of acute rheumatic fever is very high. But if you take all the three, ASL titer, anti-DNAs, anti-hydrolase, then it is almost 100% definite that the child is having an acute rheumatic fever. Of course, you do a chest X-ray to see whether there's a cardiomegaly, any other changes, pulmonary edema, things like that. You do an electrocardiogram, that is ECG, to see for the prolongation of the PR interval or other chamber hypertrophy and other changes, and echocardiogram. Definitely, you do it as a part of acute rheumatic fever assessment because you would like to recognize a subclinical carditis. Treatment, there is antibiotic therapy, salicylates, and corticosteroids. Coming to the antibiotic therapy, yes, we would like to give antibiotics for all children with rheumatic fever, even though the sore throat has occurred some 2 to 3 weeks earlier. So you give antibiotics for 10 days. There is no two words on the duration of the antibiotic treatment. It has to be 10 days. Oral penicillin or oral amoxicillin you use, probably oral amoxicillin is better tolerated. Oral penicillin taste is not that good. So oral penicillin 250 milligram BID or oral amoxicillin 45 milligram per kg per day, 3 divided doses. Or you can give 1 dose of penicillin intramuscular, but injections. I don't like to give injections for small children. The other, particularly in penicillin allergy children, you can use erythromycin, clindamycin, and azithromycin. The doses are there. Salicylates, this is the most important part of the treatment. Salicylates are the backbone of management of acute rheumatic fever. The aspirin is the main drug, 50 to 70 milligram per kg per day in 4 divided doses for 3 to 5 days. By that time, all the acute inflammation would have come down. After the 5th day, you decrease it to 50 milligram per kg per day in 4 doses. Give it for 3 weeks. And then after 3 weeks, you reduce it to 25 milligram per kg per day doses for 2 to 4 weeks. Make it 2 to 4 weeks. So it's a long treatment with aspirin to completely eliminate the acute inflammatory reaction to the streptococcal antibiotics. We use for indication for salicylate is definitely in acute migratory polyarthritis, acute rheumatic fever with arthritis and carditis, but without cardiomegaly and or heart failure. If the child is having cardiomegaly and heart failure or carditis with heart failure, then you don't use salicylate as the main drug. We'll come to that later. Non-steroidal anti-inflammatory drugs are not superior to aspirin. Don't try to use any other anti-inflammatory drugs. Aspirin is the backbone of the treatment of acute rheumatic fever. Drug level measurements usually is not necessary unless you are using a very high doses for a longer period of time when you have a toxicity setting in. And toxicity usually in the form of tinnitus and hyperventilation is the earliest manifestation of a salicylate toxicity. If there is no good response to salicylates in the first 3 to 5 days, then the diagnosis is it is not big fever. Corticosteroids, if there is a carditis with cardiomegaly, or what you call it, they say more than minimal cardiomegaly. It's very difficult to define what is this more than minimal cardiomegaly. But cardiomegaly, and if there is a cardiac failure, corticosteroid is the primary drug to be used as an anti-inflammatory drug. You start with 2 milligram per kg per day in 4 divided doses for 2 to 4 weeks. After that, you reduce it to 1 milligram per kg per day for 2 to 3 weeks, and then taper it by 5 milligram every 2 to 3 days. Add aspirin 50 milligram per kg per day in 4 divided doses for 6 weeks. It has to be given once you start, while you are tapering the corticosteroid dose from 2 milligram per kg per day. If you have to keep this in mind, if you don't add aspirin, you start tapering corticosteroids, there may be a rebound inflammatory reaction, and it may be much worse than the original inflammatory signs. So be careful when you are tapering corticosteroids. You have to add aspirin. Heart failure, if it is present, then it can be treated with anti-failure measurements like diuretics, oxygen supplementation, digoxin if it is necessary, and other supportive measures. Treatment of chorea, there is no specific treatment for chorea. It's a self-limiting event, so drugs are not necessary. Rest, you can give phenobarbital. It decreases the frequency of the abnormal movements. You can use benzodiazepines. You can use haloperidol if it is very severe. And of course, you have to have a secondary prophylaxis with penicillin for 10 years is a thing if you have diagnosed chorea as an isolated event of acute rheumatic fever. Now coming to the prevention. This is the most important thing in acute rheumatic fever because we have to really prevent the occurrence of acute rheumatic fever to reduce the load of rheumatic heart disease in the population. The primary prophylaxis is whenever child has a group A beta hemolytic streptococcal throat infection or what you call a strep sore throat, you have to treat with antibiotics, either penicillin or with amoxicillin for 10 days. That is what is primary for prophylaxis. So every time the child gets streptococcal sore throat, you treat with antibiotics for 10 days. That is a primary prophylaxis because recurrent sore throat is the cause for acute rheumatic fever with carditis and consequent complications of carditis. Then there is something called as a secondary prophylaxis. Secondary prophylaxis is you have already diagnosed acute rheumatic fever. It was not prevented because child did not have a proper antibiotic therapy or no antibiotic therapy, the child has come to you with acute rheumatic fever, and the child has improved with your anti-inflammatory treatment. Now we have to prevent further streptococcal sore throat. So that's where we call it as the secondary prophylaxis. So there are different groups which you have to see. Rheumatic fever without carditis. Okay. A rheumatic heart disease with carditis without residual heart disease, you give, if it is rheumatic fever without carditis, you give it for 5 years, okay, or up to 21 years, whichever is longer. A 15-year-old child comes to you for acute rheumatic fever, give prophylaxis up to 21 years, not for 5 years, because it becomes 20 years. So same thing, rheumatic heart disease with carditis, without residual heart disease, you have to give it for a longer period, that is for 10 years or up to 21 years of age, whichever is longer. Rheumatic fever with residual rheumatic heart disease. The child has already developed a rheumatic heart disease for 10 years or up to 40 years of age, whichever is longer, sometimes lifelong. When it is mentioned as 10 years, that means that you have diagnosed the patient as rheumatic heart disease at the age of 30 years. Then you give. Otherwise, if you have diagnosed a rheumatic heart disease at the age of, should receive the prophylaxis for up to the age of 40 years. Now, what drugs which you use? Usually it is used as a benzathine penicillin, that is a drug which you use always, and it is given in with an intramuscular route. 60,000 units, okay, if it is less than 30 kgs, or 100,000 20,000 units, which is more than 30 kgs. You give it every 4 weeks. That is better because intramuscular injection every month you give it, and it's a very complaint. You know that the child is going to get. People have used oral prophylaxis, but the problem will be it is has to be given every day. People have used penicillin, oral penicillin, sulfadiazine, and sulfasalazine, erythromycin. But every day the child has to take, so complaints will be very much a problem in oral prophylaxis. So we will not opt for a oral prophylaxis. In our situation, in our country, we should go for a parenteral prophylaxis. I think I've finished the talk. Uh, Thank you very much for being here and asking. And let me see whether you have any questions so that I can uh, talk about it, answer some of your questions. Yeah, there is still I have about 15 minutes. That's good. So I've finished it early. Huh? So we have time until the if there are any questions, please write down. Let me see whether I can make out any questions. Hello, how do I? Hello, how do I? I can't. Yeah, this is here. Yeah, there are no questions. Participants are 145. I can see the number, but none of you are saying anything. Can you hear me? That's another problem. If you have not responded, huh? Okay, yeah. Oh, somebody left early because uh, heavy rain, no power since night. That's okay. That's okay, Satish. Huh? And yeah, to all families. Yes, sir. Yeah, tell me, how was it? Yeah? Yeah, it's finished. And no, I just want to know whether there are any questions. You have any questions to ask, my dear students? There are 144. There is not even one question coming forward. Okay, thank you very much. Thank you.
Finished, sir.
Ah,
Shall I close the class?
yeah, well, they are not asking any questions.
Yeah.
So I opened the chat, but there is nothing coming. Up to 9 a.m. There is something, yes sir, yes sir. So they have heard me clearly. Huh?
Yeah. Okay. Shall I start, sir?
Yeah, please stop. Because if there are no questions, then there is no need to continue.
Question answer also. Thank you, sir.